That was terrific. I'm going to go make some anonymous phone calls on my way home and see what we can come up with for our program. So we are going to switch back to clinical IORT with Dr. Sudha Amarnath, who is an assistant professor of medicine at Cleveland Clinic Lerner College of Medicine and director of colorectal and gynecologic malignancies for the Department of Radiation Oncology at the Cleveland Clinic. She attended the Massachusetts Institute of Technology for undergraduate studies, where she studied chemical engineering and biology. She subsequently graduated from the University of Michigan Medical School and completed her residency training in radiation oncology at the University of Washington in Seattle. Today, she will be talking about the use of intraoperative radiation therapy in rectal cancer. Thank you.
Good morning. Thank you so much to the organizers for the opportunity to present today. Just a quick question out in the audience. How many of your centers are using intraoperative radiation therapy for applications outside of breast cancer? Okay, so a few. And are you using are you using it in GI malignancies? Okay, wonderful. So today I'm gonna briefly review a little refresher on rectal cancer, since I know many of you in the audience treat a lot of breast cancer, and that's been the main focus of this conference today. Then talk about some of the indications for IORT, as well as the evidence for IORT and our experience at the Cleveland Clinic. So colorectal cancers are very, very common in the United States. They're the third most common type of cancer in both men and women. And unfortunately, despite advances in screening, there's still a high mortality rate. It's the second leading cause of death in male patients and the third leading cause of death in female patients after breast cancer. With screening, the incidence of rectal cancers have gone down about 3% in patients over the age of 50. However, unfortunately, and for reasons that have not been elucidated as of yet, the incidence of rectal cancer is actually increasing in patients under the age of 50 by about 2% now. Anatomically, we're moving from the top of the body down to the rectum, which is obviously the lowest part of the colorectal tract. The anatomy of the rectum is very important because it has a lot of implications for ultimately the overall treatment of this disease as compared to colon cancer. I have a picture, a sagittal view of the female anatomy, just to kind of remind everyone of how much is really packed into the pelvis. In the female, you obviously have the uterus that sits anteriorly, as well as the bladder and the vaginal canal. And in the male patient, you have the prostate gland, the seminal vesicles. The rectum is surrounded by a mesorectum. I'm going to show you some more pictures on the next slide. And ultimately, getting a negative resection margin in the pelvis can be very, very challenging for the surgeons because of the tight space that they're operating in, as well as all of the structures that are close by. MRI has really been a big game changer in the field of rectal cancer and is now considered standard of care in the workup of these patients. And that's primarily because we can get much better upfront clinical staging of these patients. So you have the rectum that sits in the posterior portion of the pelvis surrounded by the mesorectum, and in arrows you can see the mesorectal fascia, which is the plane that's used by the surgeons for total resection in a low anterior resection or an abdominal perineal resection. On the MRI, you can get very good information about the proximity of the tumor to the circumferential resection margin, which is the edge of the mesorectal fascia, as well as improved nodal staging, which can help select patients for appropriate therapy. Rectal cancer is staged using the depth of invasion into the wall of the rectum. So T1 and T2 tumors are primarily confined to the wall of the rectum. As you get into more advanced tumors, such as a T3 tumor, you're getting into the mesorectal fat. T4 tumors actually go into surrounding structures such as the vagina, the uterus in female patients, or the prostate gland, seminal vesicles, or bladder in male patients. As you get further and further into either the mesorectum or into other structures, the risk of nodal involvement also increases with that. And that has implications, again, as to how we treat these patients. So nodal failure is one of the things that we worry about the most in the pelvis, and I'm going to talk about that in a little bit more detail in just a bit. But in terms of the patterns of failure, the location of the tumor really kind of helps inform us as to what areas are at highest risk. So in basically all patients with rectal cancer, perirectal and presacral lymph nodes are considered at risk, as well as the internal iliac lymph nodes. If the patient has lower rectal or anal canal involvement, especially if there's sphincteric involvement or really anal canal involvement, then the superficial inguinal vessels and lymphatics can be at risk. And if there's anterior invasion in the pelvis, then the external iliacs can be at risk. So the treatment paradigm for rectal cancer is in early stage tumors that are confined to the wall of the rectum, total mesorectal excision. And the outcomes with total mesorectal excision in that patient population are excellent, with recurrence rates that are on the order of less than 5% now with very good surgery. In locally advanced tumors, which are T3, T4, or node-positive tumors, the standard of care is to do neoadjuvant radiation or chemoradiation, total mesorectal excision, and typically that's followed by adjuvant chemotherapy. With neoadjuvant radiation, the goal is really to sterilize the lymph nodes that are in the pelvis that will not be resected at the time of surgery. So the presacral lymph nodes, the internal iliac lymph nodes primarily. And with chemoradiation, you get the benefit of sterilizing that microscopic disease in those other lymph node groups, as well as potential downstaging of the tumor to help the surgeon get a negative circumferential resection margin. So this is just an example of the 3D conformal plans that we typically use. This is an example of a T3 node positive tumor, just to kind of show you what's typically treated up front in this patient population. The doses are typically limited by small bowel when we're treating the pelvis. So the doses have typically been around 50 gray or so when we treat preoperatively, which we know in patients with more advanced disease may be dose limiting or maybe rate limiting for ultimately getting good local control of these patients with more advanced tumors. So this is just what that will look like, treating all of those spaces that I mentioned previously. So the risk of pelvic recurrence is really what we worry about most, at least from a radiation standpoint. So our best outcomes in locally advanced rectal cancers are with preoperative therapy as well as good TME surgery, so an R0 resection. In the German rectal study, which is the major study that we use to inform our current treatment paradigm, the risk of local recurrence in that population was about 6% at 5 years and 7.1% at 10 years. That's pretty good, but when you think about the patient population that was included in that study, there were a number of T3 node negative patients, as well as some patients who were probably staged incorrectly and had lower stage disease than what was supposed to be included on that trial. So the recurrence rates, if you actually have a T4 node positive tumor, especially in the setting of an R1 resection, are really much, much higher, on the order of 20 to 30%, or even higher than that. Pelvic recurrences can be extremely morbid with pain, bleeding, bowel obstructions, and very poor quality of life noted in many of these patients. So where does IORT fit into all of this? So IORT can really help decrease recurrence risk. Most of the data that we have is retrospective and single institution, but many of these studies do suggest a local control benefit for locally advanced or recurrent pelvic tumors, especially if there are close or involved margins. So these are just some examples of patients who may benefit from a dose escalation strategy. Patients with locally advanced disease, especially those with threatened circumferential resection margins, this typically tends to be the anterior margin, which can be difficult for the surgeon to get a negative margin around without potentially some sort of exenerative procedure, removing the prostate, as well as maybe doing a hysterectomy, a vaginectomy in certain patients. In recurrent disease, they're typically located in the presacral space or the pelvic sidewall. And this is just an example of a patient who recently came to us with a presacral recurrence. This patient had a rectosigmoid tumor that had not been previously treated with radiation and then recurred at the anastomosis with extension into that presacral space. This is an example of a pelvic sidewall recurrence, a patient who had an external iliac lymph node. You can see the CT on your right, and you can see more clear soft tissue delineation on the MRI next to it, and you can see kind of how the vessels are very close by. And in these presacral and pelvic sidewall recurrences, you oftentimes have vessels, nerves that really can limit the resectability of these recurrences by the surgeons. And this is an example of a very large presacral recurrence, which we unfortunately still see. And in these patients, we often will perform reirradiation in combination with intraoperative radiation therapy to achieve better local control. And this is just an example of a reirradiation case. Typically at our institution we use 39 gray and 1.5 gray BID fractions, and then we'll follow that with IORT boosts to any areas that are considered at risk by our surgeon. So this was a paper that was published from our institution back in 2012, and it was the first paper using the intrabeam system for IORT in locally advanced and recurrent rectal cancer patients. So in this study, 42 patients with locally advanced or recurrent rectal cancers were treated with intrabeam IORT after definitive resection between 2000 and 2009. The dosing came from the breast cancer experience, so 5 Cray prescribed to 1 centimeter depth. Surface doses ranged, as you can see, from 13.4 to 23.1 gray, but the median surface dose was about 14.4 gray. In terms of the patient characteristics, you can see I highlighted that the vast majority of these patients were recurrent, 76%. Most of these patients had had pelvic radiation, almost 90% of patients. The margin status at IORT was based off of whether the surgeon thought there might be a positive margin, or it could have been based off of frozen section, and about 45% of patients had a positive margin status at IORT, and on the final sections, that was about the same at about 45%. And you can see the overall survival curve for all patients treated in this study. The median survival was about 34 months. Obviously, this was not a randomized prospective kind of study, so all we have is historical controls. But for patients who don't have an R0 resection in the recurrent setting, the 5-year survival in these patients has been 0% historically. And here you can see at about 5 years, that rate was just under 20%. Again, looking at overall survival for recurrent versus locally advanced disease, you can see that the advanced patients do better than obviously those patients who have recurred. So median survival was about 49.2 months in that patient population versus 32.1 months in the recurrent setting. And this figure next to it is showing local recurrence-free survival. And essentially you can see that these patients are actually doing very, very well from a local recurrence standpoint. Ultimately, many of these patients are then failing distantly, and ultimately, you know, we really need better systemic therapy options for these patients. This is just a comparison of our data compared to many of the other published series. Most of these series were done with electron beam radiation therapy intraoperatively, but you can see that our outcomes basically are in line with the outcomes that have been reported by other centers who are also doing this technique. The same is true. We only had 10 patients in our series with locally advanced disease, but again, the 3-year local control was 100%, and 5-year survival was 39%, which is very good compared to historical controls in this population. So this is a more updated experience that is actually being presented at ASTRO this year. We have 87 patients treated between 2000 and 2016. 91% of patients in that study have recurrent disease. 70% received prior external beam radiation, and 46% had positive margins. Again, the dose was 5 gray, prescribed to 1 centimeter. In that study, interestingly, For R0 resections versus R1 resections, the local recurrence rates were exactly the same at about 30%. And on the univariate Cox regression analysis, margin status, histology, IORT prescription dose, and surface dose or tumor size were not predictive of local control, which really seems to imply that the use of intraoperative radiation therapy can help make up for an R1 resection. I know there was some talk earlier about, in the breast cancer setting, re-excision versus the use of IORT. You know, in this setting, these patients typically can't undergo re-excision based off of their anatomy and where these recurrences are located. So I think this updated data actually is very meaningful in terms of what the role of IORT is and ultimately how it can really benefit these patients. When you think about toxicity in this patient population, neuropathy is the one that's been most described in the literature. Most of the data suggests that if your surface dose is 15 gray or less, that the neuropathy rates are quite low, and in our study it was about 5.7%. Ureteral stent placement and hydronephrosis were the most commonly seen toxicities, but most of those patients also had tumors that were causing some of these symptoms as well. So hard to know if it actually was related to the intraoperative radiation therapy versus just tumor itself. Infection rates and radionecrosis rates were extremely low. So at our institution, our indications for using intraoperative radiation are basically what we just talked about: locally advanced or recurrent patients where the surgeon is concerned about a close or positive margin at the time of surgery. We use a team approach, so these patients are typically presented at our multidisciplinary colorectal tumor board. We actually have now a recurrence team that is available for these cases because they can involve a number of surgical specialties. So there's obviously the colorectal surgeon, but we also have orthopedic oncologists, GYN oncologists, urologists, neurosurgeons, plastic surgeons, and radiation oncologists on this team to really discuss these cases in advance so that we can advance plan and be ready when these patients go to surgery. So our process is that, of course, the patient's referred for consultation and consent is obtained up front. The physics team is notified of the IORT case so that the intrabeam is calibrated and ready to go on the day of surgery. The resection's then completed by the surgical teams. Frozen sections are often obtained to help determine margin status. And if the IORT is deemed necessary, we use the IORT applicator. Previously, we just had the spherical applicators that are also used in breast cancer, but more recently, we also obtained a flat applicator, which can be placed directly against the area at risk, and that's typically done by our primary surgeon, as well as the radiation oncologist, who will be part of that case. Normal tissues are then retracted or can be protected by flexible lead shielding, especially the bowel and the ureters are areas that we really want to make sure we keep out of the way. Essential personnel, as in breast cancer, treatments stay in the operating room with lead apron shielding, and then the IORT is delivered. Because we're typically using the largest size spherical applicator, about 5 centimeters, the median duration of treatment time is typically about 35 minutes. And then our team leaves and the surgical team returns to close the patient. So these are just a few pictures of the intrabeam IORT in action. I actually put a picture up here of the surface applicators, although we actually use the flat applicator, which looks similar. So in conclusion, photon intraoperative radiation therapy is safe for use in locally advanced and recurrent rectal cancers and may improve local control even in margin-positive patients based off of multiple retrospective series as well as our own institutional data. Advanced planning and multidisciplinary approach are really key in these cases because of how challenging the surgical approach can be. In terms of future directions, just like this meeting, which is a wonderful opportunity for people to meet, we are trying to kind of put together an international consortium to further study the use of IORT in pelvic malignancies. It's a difficult area to have prospective data, so the more that we can pool data and have larger patient numbers, I think the more that we can show what the benefit of intraoperative radiation therapy is in these tumors. And feel free to email me if you are interested in being part of this as well. And this is our new cancer center at the Cleveland Clinic. So thank you so much for the opportunity, and I'd welcome any questions.
That's great. So I have a question.
Sure.
Thank you, that was wonderful. Great talk. Can you speak a little bit to some of the positioning considerations in the OR? Dr. Mahadevan, who was at your center, is now practicing with us, and he was describing some of the issues of positioning the patient in order to move organs away from the source. As we all know, distance is critical when it comes to protection of critical structures, and also some of the shielding techniques for neurovascular bundles that are used during rectal IORT.
Sure. So again, I think, the advanced planning is really key, because we typically will kind of sit together as a group to look at the MRI and really discuss in advance what those normal structures are, so that by the time we even get there with the intrabeam, oftentimes those tissues have been retracted by our surgeons. So we use a lot of retraction devices. Again, the flexible lead shielding, you basically place it in a plastic bag, and you can use multiple sheets of this. And usually
those are the blue shields that are used for breast too, correct?
It's the one
them?
that you put inside of the patient. Do you guys use those as well in breast? I don't treat breast IORT, so.
Yeah, okay.
So I apologize. But yeah, there's just these flexible lead sheets that can be placed internally. And like I said, we usually use sterile plastic bags. And essentially, the surgeon is present to identify structures such as the ureter, neurovascular bundles that we want to avoid. And then that shielding is just placed directly into the patient to shield those structures from dose.
And are they always intra-abdominal delivery? Do you ever do anything from the perineum, or is everything, do you ever run into situations where access is an issue from above?
Typically they've been intra-abdominal approaches, but I also treat gynecologic tumors, and we use IORT quite frequently in that setting as well. And I have had a few patients where we have gone through the perineum, and it's worked quite effectively. It's whatever's going to give you the best exposure and ultimately allow you to place your applicator. But any of those have feasible, as long as you plan in advance.
And this is my last, what is the most common applicator? Is it spherical or the flat applicators? What do you find you use most with the rectal patients?
So we only recently got the flat applicator, only within the last 3 months. So we had been previously primarily using the spherical applicator, but the flat applicator is wonderful because you don't have to worry as much about the bowel and everything else, especially when we're treating the pelvic sidewall or the presacral space. So I really prefer the flat applicator, but all of our data comes from using the spherical applicators.
Hello, yes, this is thank you very much for an excellent presentation. Sure. It was in 1999 or 2000 that after doing the first few patients in breast, we did the first 2 patients in rectum, because our department and the professor, Irving Taylor, was a specialist in colomastology. So that was a key word, colomastology. Anyway, they don't use it anymore. But I then got distracted in doing only breast, so we didn't do any more cases there. But I had visited Cleveland Clinic around 1999, 2000,
Sure.
and we spoke about this. And it is so nice to see all this happening. Two or three things. One, with the number of events that you have, 29, 30%, the number of patients you would need in a randomized clinical trial is not large. So you would then get control data to see local recurrence rate without IORT or with EBRT in addition to see the toxicity. You would also be able to collect fluid from these patients from the peritoneum, because drains are commonly put after such operations. So you could collect the fluid and see how it is different between surgery alone and surgery and IORT. So that would give biological insights. So I would really encourage you not to have this as standard treatment, be convinced about it yet. So please do the trial.
Yeah, and actually, I 100% agree with you. It's funny, in CNS we have the believers versus non-believers trial, and I would put myself in the non-believers category for a very long time. And I agree. I think we need randomized data as much as possible. I think the challenge is that once it has been made available, it is often hard to convince those people, and I'm not disagreeing with you. All I'm saying is that I know that's a challenge at our institution because we have a lot of very strong believers who would think that not giving IORT was actually lessening lessening their outcomes, and ultimately, would not be the right thing to do. But I agree with you.
Yeah, it's ethical. It's not ethical to do a trial, not to do a trial.
Right. Absolutely. Absolutely.
Well, although NCCN guidelines recommends IORT in this setting when available, so it is challenging to do a randomized trial in the face of guidelines that already endorse the use of IORT for these patients. So I don't think that trial's going to get done. There you go.
Right.
The reason for this group.
Thank you. That was an excellent talk. I really enjoyed. My comment actually is related to what Dr. McKee was saying earlier about the choice of applicators. Since we are very fortunate, we got the flat and surface applicators. Thanks to Zeiss, we've been using those. And I think the treatment planning considerations, the dose, shieldings, they will change when you move from spherical to flat. So it'll be really interesting to know how you prescribe your dose, what depth, and some of the experiences in that area.
So I know in most of this experience, it was 5 gray to 1 centimeter. I would say more commonly now, we're prescribing to the surface and typically limiting the doses to about 15 gray based off of all of the data that suggests that peripheral neuropathy increases once you're above that threshold. So that's typically how we're prescribing, is now more to the surface as opposed to the 1 centimeter depth. Especially because in these cases, that's really where your at-risk area is at the surface with the margins.
So, quick question, would you prefer then using surface applicators or something to be, I guess, looked into, right?
Well, the flat applicator ultimately is like a surface applicator, right, in that it's going directly up against that space. So that's why I prefer that over the spherical applicators.
Thank you.
Mm-hmm.